Urinary tract infection is one of the bread and butter for the general practitioners during the summer months in the country. India being a tropical country, we are seeing it quite a lot of urinary tract infections in the summer and the tropical season. Pediatrics is one area where definitely treatment is going to be in your hands initially before the patient shift over either to the pediatrician or necessarily to a pediatric surgeon, where you are now going to see Dr.kasi from Chennai, who will try to give a brief of the entire urinary tract infection leading on to the surgical stage of phimosis, balanophthyosis, anything.
I am Dr.kasi, pediatric surgeon and pediatric urologist, Dr.kk Surgical and Pediatric Center and Deepam Group of Hospitals, Tambaram, Chennai. I am here to talk about the urinary tract infection in male children. 3 to 5% of children suffer from urinary tract infection. The common presentation may be urgency, frequency and dysuria, which often neglected. But when there is pyuria or enuresis, one has to look up the reason for that and find out and treat the urinary tract infection properly. The general practitioner should be aware the UTIs can also present with unexplained fever, abdominal pain, recurrent loose stools and recurrent respiratory tract infections, sometimes poor weight gain. It can present with 4 different forms. 1. Balanophthyosis, 2. Urethritis and cystitis, number 4. Pyelonephritis. The balanophthyosis will occur only in males, as you all know. Other 3 can occur in both sexes. The hematogenous spread is very uncommon, whereas ascending or retrograde infection is the main source of UTIs in children. UTIs are more commonly occurs in children with voiding dysfunction or dysfunctional elimination. Bladder abnormalities, both functional and anatomical abnormalities, will contribute for the urinary tract infection in a big way. When there are associated anomalies like anorectal anomalies, vesicoureteric reflux, bladder outflow obstruction and sometimes constipation can also lead to urinary tract infection. So, constipation is the cause of urinary tract infection in most of the children, whereas the diarrhea may be the presentation or effect of urinary tract infection. How to diagnose? It is very easy to diagnose with simpler test, but it is often misdiagnosed. The urine routine examination, when there are 3 or more pus cells, it clinches the diagnosis of urinary tract infection. Urinary and urine culture and sensitivity often gives you the idea of culture positivity, and also dipsticks with leukotriene esterase test and nitrate test. Dipsticks will give the diagnosis of urinary tract infection in no time. But these tests available everywhere, but interpretation and usually they are misinterpreted, and also they have high index of false negativity. So, one has to be very suspectful when they diagnose urinary tract infection. When they have high index of suspicion, they should do ultrasonogram examination, which will give you the idea of urinary tract in a better way. And also, when the ultrasound examination reveals you something in upper tract from bladder to kidneys, all general practitioners and family practitioners should bear it in mind. They have to undergo further tests like voiding cystourethrogram. It will give you the idea of outflow tract as well as the upper tracts. And also, we have to insist on DMSA, the nuclear scan with dimercaptosuccinic acid, which will give you the idea of renal scarring. The renal scarring, I have to mention, they are irreversible. We have to catch the patients, children with UTIs and treat them before the renal scarring occurs. So, treatment. As you all know, the commonest problems causing UTIs in children are phimosis and balanophthyosis, and whereas the vesicoureteric reflux causes infection in more than 25% of the cases in both sexes, and short urethra is implicated as the one which causes more incidence of UTI in females. The profuse of the male acts as a reservoir for uropathogenic bacteria. So, ultimately the profuse should go. The uncircumcised boys have more than 10 times of risk of UTI than circumcised boys. The Phimosis is the commonest problem in pediatric urology and commonly diagnosed every time, everywhere by the GPs and family physicians. By definition, the inability to retract the profuse is called as phimosis. But we have to be very careful when they are physiological and when they are pathological. Up to 1 to 2 years of age, it may be physiological. I should say it may be because even in this age group, when there are symptoms like dysuria, balanophosphatitis and history of recurrent urinary tract infection, one has to diagnose it as a pathological phimosis and treat with circumcision. So, the pathological phimosis is defined one which presents with dysuria or ballooning of profuse and balanophosphatitis and meatal stenosis and balanitis xerotica obliterans, shortly called as BXO. Phimosis is caused by more than 90% of cases by infection, and some of the cases may present with post-traumatic as well as post-burn cases. The balanophosphatitis is often misdiagnosed as ant bite, but usually 100% of cases they are due to balanophosphatitis, which is often ignored. So, coming to the treatment, the commonest cause being phimosis and balanophosphatitis, and most of the practitioners, the family physicians recommend medical treatment which includes gentle stretching, steroids and antibiotic grams and so on. But it should be taken as a time gaining procedure before doing the circumcision, which is the surgical treatment which is the mainstay for phimosis and balanophosphatitis. So, coming to the indications of circumcision, the phimosis which is pathological, the paraphimosis, balanophosphatitis and BXO, that is balanitis xerotica obliterans and recurrent urinary tract infections. Recently, I had a case, a VIP child, a child of a doctor, 9 months old child suffering from recurrent urinary tract infection, but the treating family physician and pediatrician felt it could be a physiological one. When they came to us, because of the apprehension by the parents, we need to undergo ultrasonogram and voiding cystogram, ultimately DMSA scan, everything proved it was a case of urinary tract infection. The DMSA scan clinched the diagnosis of pyelonephritis. So, he underwent circumcision at the age of 9 months, and paraphimosis, that means inability to pull back the foreskin which is trapped behind the corona of the glands. If it is left as it is, it may lead to gangrene of the glands. So, it is a surgical emergency, gentle reduction. In resistant cases, it may require dorsal slit and circumcision. And what is BXO? That is balanitis xerotica obliterans. It is a part of midline fibrosis. It is a progressive disease. It can cause perimeatal fibrosis because of ammoniacal dermatitis, which may lead to depigmented patch. And because of these depigmented patches and white patches, the GPs and family physicians often refer such cases to a dermatologist. Dermatologists in turn refer those cases to us, diagnosing as balanitis xerotica obliterans, which will lead to pain, irritation and meatal stenosis. Remember, this is one of the precancerous lesions for carcinoma of penis in the later ages. The circumcision cures both urinary tract infection as well as it prevents the chance of carcinoma of penis at a later age. Circumcision also has some contraindications. The bleeding disorders and filarial disease of penis are relative contraindications, whereas when they are associated with congenital anomalies like hypospadias, one should not do circumcision. It should be left to the experts like pediatric surgeons. And circumcision also has complications. I have to mention this because as a family physician, to whom you should refer such cases is paramount importance, because when there is a setting of bleeding disorders, the bleeding itself can kill the child, which may be a fatal one. And in some of the cases, very rarely, infection and skin necrosis can come. The picture shows the meatus as receded to the penoscrotal junction, and we had to do staged procedures to correct the problem. And as a complication, meatal stenosis also can come as a complication of circumcision, and secondary phimosis also can come in unexperienced hands. But as a word of caution, I should tell you, as a GP, don't say or never say such any procedure as a simple surgery. No surgery is simple, and every surgery can be a difficult or can lead to problems in later life. With this word of concern, I expect all GPs and family physicians to be aware of the urinary tract infection in children, and they have to, when they have the high index of suspicion, they have to do ultrasonogram screening in all cases of urinary tract infection, even in the case of culture negativity, because the ultrasonogram is one which will pick up the early cases. In some of the cases, if you have strong suspicion of urinary tract infection or recurrent febrile urinary tract infections, you need to go for DMSA scan, that is nuclear scan, done with 99M technetium tagged dimercaptosuccinic acid. It's not a costly one as you all think. It's a sophisticated investigation which may pick up the renal scarring and injury to the pyelonephritic spots in the kidneys. With this advice, I conclude the topic on urinary tract infection in male children. Thank you very much.